Good morning, everybody, those who are present here and those who are joining us virtually. I'm happy to announce today's weekly research conference featuring the Margaret and Theodore Marr Endowed Lectureship in Electrophysiology. The lectureship was established in 2006 by Mr. Robert Marr in honor of his parents, Margaret and Theodore Marr. The Marr family has benefited from the services of the Institute, and Margaret was a much admired member of the Heart Institute Auxiliary in the 1980s. They have generously funded this endowment in recognition of the Institute's leadership in education and research. Electrophysiology is an area of tremendous opportunity, and this lectureship will help advance new developments in the field. The lectureship is a permanent fund that enables us annually to bring the world's foremost experts in cardiovascular medicine and research to the Heart Institute for a formal exchange of ideas. Dialogue, the exchange of information and research will ultimately lead to the reduction, if not the end, of heart disease. The generosity of an endowed lectureship permanently embeds this important process in the life of the Heart Institute by providing the resources required to maintain this rich exchange year after year until heart disease is eradicated. We have had very distinguished lecturers in the past, including Michel Geisinger, and just to name one. And we are honored to welcome Dr. Pugazhendhi Vijayaraman. Pugal for short, it's a tough Indian name to pronounce. And for this hybrid audience, we have, for this hybrid event, we have audience members in person and virtually. As a housekeeping event pointer, if you have any questions, I'll be there moderating from the microphone here. You can walk up and then pose your question to Dr. Vijayaraman. And if those online can post their questions in the chat feature, and we'll present them to Dr. Vijayaraman. Let me introduce Dr. Vijayaraman. So he's a professor of medicine at the Geisinger School of Health Sciences, Pennsylvania. He currently serves as the director of Clinical Cardiac Electrophysiology Fellowship at the Geisinger Heart Institute, Wilkes-Barre in Philadelphia. And he's also the system director of electrophysiology for the Geisinger Heart Institute. His research interests include physiologic pacing, such as his bundle pacing and left bundle branch pacing, and also does ablation therapy for atrial fibrillation and ventricular arrhythmias. He has dedicated the last 2 decades of his life to pioneering novel approaches to physiologic pacing, including his optimized CRT or hot CRT and left bundle based branch pacing CRT or LOT CRT for patients with heart failure and complex conduction disease. And on a personal note, I know him for the last 2 decades. When I was a medical student, he was the first and second year internal medicine resident. And even at that time, when he used to take clinical classes for us, we were very impressed with his very sensible way of dealing with medical problems. And he has done that through his career in the US. And it's a privilege to have him here. He's probably written more papers last year than I've written in the last 10 years, which is a huge number, and all in high impact journals. So without further ado, I'll request Dr. Vijayaraman to come us and talk to us today.
Thank you, Girish, for your kind words, and thank you, Mr. Marr, for this endowed lectureship. It's my privilege and honor to be able to present in this very, very nice Heart Institute. So the topic is going to be physiologic pacing or conduction system pacing for heart failure. These are my disclosures. So my first bundle pacing experience came almost 20 years ago. I had just moved from Virginia Commonwealth University in Richmond to Wilkes-Barre, Pennsylvania. It was a small town. And I was the only electrophysiologist in a group of 5 cardiologists. And I was bored, so I didn't know what to do. So all I had to do at that time was pacemakers, thinking I was going to do a lot of electrophysiology procedures. In this small town, which was the oldest county in the United States, I didn't know that at that time. So I was doing a lot of pacemakers. And this was a 74-year-old man with persistent AFib, bradycardia, and LV ejection fraction was 40 to 44%. I read a paper from Francisco Zanin in Italy, who had published this report of ability to do hispanal pacing. So I did this. This is baseline electrocardiogram. I was able to do hispanal pacing. And this is almost 12 years later. This patient who had AFib was able to maintain sinus rhythm, and his LV function had normalized. Little did I know that this would have been such impactful in this patient. But my first case was pretty easy, straightforward, didn't take much time. I thought this is going to be pretty good, and I can do this for most of my patients. But obviously, you learn and the challenges of how to do hispanal pacing. For those audience, the traditional pacing for bradycardia is right ventricular pacing when you do. So when you place the right ventricular pacing, the activation is not normal. It's an artificial form of stimulation. And so utilizing the native conduction system, it's almost like this joke came before I could play the video. It's just you fixing the problem. You don't have bradycardia anymore, but it's not the same as your normal leg. And so that leads to abnormal problems in the long term. So there's a lot of electromechanical dyssynchrony, there's abnormal myocardial metabolism, there's cellular and genetic changes in maladaptation that leads to what we call as pacing-induced cardiomyopathy. If you look at decrease in LV ejection fraction as a marker of pacing-induced cardiomyopathy, that's about 10 to 20%. That happens in 3 to 4 years after RV pacing. Good number of them don't develop LV dysfunction, but there's a lot of other factors that happen. So people who develop heart failure, people who develop atrial fibrillation, high BNP levels, all these are indirect effects and direct effects of right ventricular pacing that we ignore because we don't attribute to the pacing. So hispanal pacing, if you think of RV pacing, is just placing the lead anywhere in the right ventricle, as you can see in this ventriculogram with contrast injection. But hispanal pacing is placing the lead in this one particular area, a small region in the AV annulus between the atrium and ventricle, and finding that small area, that's going to be challenging. And 2 decades ago, there was not a lot of tools to find this little strand of specialized electrical tissue that actually goes on to innervate the entire ventricle and to activate it pretty efficiently. And so we have to play with the tools to find this particular location. We can map the electrograms, find those sharp potential, and place the lead. However, this is challenging because unlike the myocardial-rich environment in the ventricle, this is in the middle of a fiber structure. Unless you're directly on the his bundle, your capture thresholds are higher than what you would normally get for ventricular pacing. So your pacemakers don't last as long. So we have to be pretty efficient in doing this. So it took several years for me to develop a technique that makes this more optimal. And by that, we were able to achieve 80 to 90% success in most patients that needed ventricular pacing. But we still need a lot of skills and learning curve, and it was hard to reproduce by lots of other centers, and often associated with high capture threshold, early battery depletion, and all of those issues associated with it. But it was worth the price at that point because we didn't have anything better. And so by pacing the electrical system, you could activate the heart as good as what God intended it to be, what the nature was. So the incidence of pacing-induced cardiomyopathy and other LV dysfunction was significantly less. Well, I was enamored by hispanal pacing. It wasn't something I invented or I figured out. This has been going on for 5 to 6 decades before even pacemakers came into work. And electrical system, understanding the His-Purkinje system was well known before, and early attempts at animal studies were unsuccessful. However, permanent hispanal pacing was done in the year 2000, and was from one of the centers, again, rural Pennsylvania, not far from where I was, Dr. Deshmukh, and he figured out with even more primitive tools, with just stylet-driven leads, to reshape the stylet would take 3 to 4 hours to place the lead in the specific location. But he was able to do it, show that it is feasible. But despite years of advances, industry, unfortunately, were not willing to invest in this technology because biventricular pacing was another form of artificial form of pacing, but it's very effective form of pacing. And so hispanal pacing was associated with challenges. And while trying to improve this procedure, another colleague of mine from China, Dr. Wang, developed a method where you could place the lead deep into the septum and get to the left bundle branch on the LV endocardial surface. The advantage of this was that the lead can be placed in a myocardial rich environment. So you have thresholds are good, your sensing is not a problem, and you almost always have left septal myocardial capture in addition to conduction system capture. So this became the go-to therapy over the next 4 to 5 years since its introduction in 2018. And so what does that involve? So if you think of the His bundle as a tiny little structure, the left bundle and the right bundle are pretty extensive Purkinje network. It's like the highly sophisticated innervation. So you have a much larger area where you can reach and place the lead. The only challenge is that this particular left bundle branch, you cannot visualize from the right side of the heart. And it's on the left side of the heart, LV endocardial septum. You have to guess where this is going to be, develop methods to successfully place the lead, advance the lead deep in the septum, and get to the left bundle branch. But that has been successfully doable by using some anatomical landmarks and trying to get to this much bigger, thicker structure on the left side. And so why go through all of this process? Because by activating the native conduction system, you can avoid the ill effects of right ventricular pacing. So once this technique has been developed over the years, now we can use conduction system pacing for two purposes. One is you can use to maintain synchrony in those patients who have AV block or those who need AV node ablation. Now you can maintain the synchrony if they had narrow QRS at baseline. Or you can restore synchrony in patients who have dyssynchrony due to bundle branch block, IVCD, or mixed conduction disease. What type of pacing do you use? Depends on the type of conduction disease you have. You have AV nodal disease, infranodal disease in the His bundle, or diffuse disease. There you can use combination of therapy, either His bundle pacing, left bundle pacing, or combining His or left bundle with the traditional coronary sinus pacing. So why should we do it? So early on in our health system, we have multiple hospitals, as we were discussing earlier. And in the hospital that the two of us were the electrophysiologists, we would attempt from 2009 onwards, every single patient that needed a pacemaker, we would attempt His bundle pacing. Over the next 5 years, we were able to get a success rate of close to 90%. Well, my colleagues in the main hospital wouldn't do it because there's no evidence that this is any better. But they formed my control group over the years. So we were able to demonstrate that by doing conduction system pacing with His bundle pacing, we could reduce the incidence of death or heart failure hospitalization or need for biventricular pacing. With this approach, the number of patients that needed any upgrade for RV pacing-induced cardiomyopathy went to less than a single digit in our hospital, while my colleagues still had a 20% upgrade in their practice. So that can be something that can be completely eliminated. When the left bundle branch area pacing came along, we were able to show that in a 2-center study that this thing was still as good or better than right ventricular pacing, but as good as His bundle pacing. So now we have a form of pacing that you can either use His bundle pacing or left bundle pacing for the type of conduction disease that the patients have and overcome all of the challenges associated with His bundle pacing. So this is our experience by doing conduction system pacing in patients who have AV block. So it's a consecutive series of 333 patients. Majority of them had AV nodal disease. And you could do either His bundle or left bundle pacing in them and look for the best capture threshold. What was interesting was that we were able to demonstrate that the remainder of the patient, those who what we call as infranodal block or block in the His bundle or below, almost 90% of them were clearly demonstrable to be at the level of the His. That means you can correct by His bundle pacing, Or these are patients who have HV block but have narrow QRS, or sometimes wide QRS but have split His potential, or pace at the His bundle and correct them. Or sometimes you do left bundle pacing and you can demonstrate that the distal conduction system is intact and pretty normal without disease. So the number of patients who had distal disease or diffuse disease were only about 4%. So those patients we could demonstrate 2-to-1 left bundle to ventricle block, or sometimes really long left bundle to ventricle potentials, suggesting that the distal conduction is disease. So by this approach, we're able to demonstrate that you can achieve conduction system pacing in 97% of the patients in our group of all comers, consecutive patient with heart block. And so now this is a form of pacing that's equally efficient, safe, and effective, similar to the traditional right ventricular pacing. In this small study in our center, we're able to show that there was no big difference between His bundle or left bundle branch pacing in terms of clinical outcomes. So they're equally similar in terms of their efficacy. While this was a single center study, now we have real world data. This has been adopted all around the world. And especially in the US, we looked at the Medicare population and looking at about 23,000 patients who had dual chamber pacemaker, about 6,000 patients who had either His or left bundle branch pacing, and about 17,000 patients with right ventricular pacing. And we're able to demonstrate in this large cohort of patients the incidence of heart failure hospitalization and death were significantly reduced even at 6 months of follow-up. So we can see the impact because the number of patients who get pacemakers in the world is globally about 1 million pacemakers a year. Consider the impact this particular therapy has made in terms of reducing morbidity on our patient, in addition to possibly reducing mortality. So that's in terms of prevention of heart failure. That's as important as treating heart failure because you don't have to go back and upgrade these patients. But this same approach, can it be extended to cardiac resynchronization therapy? Because biventricular pacing is such a strong therapy for so many years. Now, consider this as an artificial form of pacing. You pace from the opposite direction to shorten the activation time. And despite its crude nature of this type of pacing, this has been one of the most effective therapy for heart failure over the years. And despite that, despite the advantages of biventricular CRT, the limitations are that a significant number of patients, when we do biventricular pacing, you introduce unnecessarily prolongation of activation time, similar to RV pacing, especially in those with narrow QRS. Or in those with wide QRS, you don't achieve the full electrical resynchronization. So you leave something behind on the table, which you could have achieved if you had more effective form of pacing. And the effect of this is that in almost all of these trials, about a third of patients don't derive the maximal benefit of biventricular pacing. So you still leave out a good number of patients that could benefit from a better form of cardiac resynchronization therapy. And how does conduction system pacing works? Despite the challenges of BIV-CRT, if you look at patient-specific population, take patients with left bundle branch block, which is the group with the most significant amount of ventricular dyssynchrony. I'll give you an example of a patient with left bundle branch block. So here is His bundle pacing. You have a QRS of 190 milliseconds, completely normalized to 95 milliseconds. We have never seen something like this with biventricular pacing in the past. And the effect of that, you can compare in series of patients. And the reason for that is that the majority of patients with left bundle branch block, the conduction disease is in the distal His bundle or the proximal left bundle. By pacing the His bundle, you can recruit the previously non-functional left bundle fibers and restore conduction in them. And here's how it works. So here's a patient with left bundle branch block. You have a pacing catheter that can record electrograms. This very nice study done from University of Chicago shows that when you do His bundle pacing, now these sharp potentials are examples of His activation. and the left bundle activation. Now you restore conduction through this bundle branch, and so you can normalize conduction utilizing the native conduction system. The same thing can be achieved with left bundle branch spacing. You can again see the restoration of conduction, activation of the Purkinje system that has been there for years in all of our conduction system. And how good is this compared to biventricular pacing, which is the therapy at this point of time, class 1 indication for most patients with heart failure and left bundle branch block? This very nice study from Imperial College London took 18 patients who had left bundle branch block and heart failure and gave his bundle pacing and biventricular pacing and did this ECG imaging study with a 256 electrode vest and showed that the activation time of reversal, how well it works with his bundle pacing compared to biventricular pacing by looking at the QRS duration reduction, the LV activation time reduction, looking at change in dyssynchrony index, and improvement in hemodynamic. All of them were significantly greater with his bundle pacing compared to biventricular pacing in the same group of patients, suggesting that you can get greater electrical resynchronization leading to greater improvement in hemodynamics. So another study, similar kind with a different type of ECG belt, showed that similar benefit can be achieved with LV septal endocardial pacing, similar to the currently what we call as left bundle branch area pacing. How about other forms of conduction disease? Here's right bundle branch block. Here's a patient with a wide right bundle branch block, similar to left bundle branch block. Right bundle branch block also is a disease in the his bundle itself. So here pacing at a higher output and at a slightly lower output, you can completely correct by pacing the his bundle alone and cause normalization of conduction pattern in the right bundle branch block. And when we do left bundle branch pacing, you can activate the left bundle, unlike biventricular pacing. By left bundle branch pacing, you maintain the LV synchrony in patient with right bundle branch block. On top of that, with the anodal capture and LV septal pacing, you can activate the RV side also earlier. Here's a patient with a wide right bundle branch block, and pacing with the left bundle branch pacing, you can narrow the QRS down. Not as impressive as with his bundle pacing, but still, the big advantage of left bundle branch pacing in this is that you don't introduce new dyssynchrony, while the patients with biventricular pacing, you can cause new dyssynchrony in them. And then there's a whole group of patients where we have not just one set of conduction disease, could be right or left bundle branch block, but mixed with diffuse conduction disease. So just pacing the disease conduction system and the distal part is disease, pacing proximally is not going to help. So here's a patient with a fairly wide left bundle branch block. His bundle pacing significantly narrows the QRS from 210 to 146 milliseconds. But that itself is a fairly wide QRS that requires cardiac resynchronization. Now add in an LV pacing. These are all at a very fast sweep speed. So now combining his bundle pacing plus LV coronary sinus pacing, you can further narrow the QRS from 210 to 110 milliseconds. So this is a similar approach with the patient with left bundle branch block and IVCD. Combine left bundle branch pacing with coronary sinus pacing by improving the activation times. So by this approach, we could show that you provide incremental benefit from baseline to biventricular pacing to conduction system pacing alone, or a combination called HART or LOT CRT can cause maximal electrical resynchronization. So does it translate into clinical outcomes? So early observational experience is a small series of 74 patients with his bundle pacing, dilated cardiomyopathy, left bundle branch block. Successful for his bundle pacing was about 75%. The study showed that LV ejection fraction in this very highly selected left bundle branch block associated cardiomyopathy was very good. Unheard of with biventricular pacing, you often get 25 to 30% hyperresponse rate. This group had about 80% hyperresponse. You could completely normalize the LV function. This was tested in similarly with left bundle branch pacing. We had similar improvement in clinical outcomes, not only with QRS duration, but improvement in LV ejection fraction and functional class. Started testing them in early randomized trials, pilot trials. This was limited at that time. We didn't understand what type of patients could benefit from this his bundle pacing. Patient selection was important. There was a lot of crossover. And this his alternate study was a better design study, showed about 72% success rate, but 28% crossover rate because of difficulty with getting good thresholds. Nonetheless, these studies showed that LV ejection fraction improvement was better with his bundle pacing compared to biventricular pacing. Then came the left bundle branch pacing, because now we can overcome the conduction disease more effectively with left bundle branch pacing because we are distal to the side of block. And this small randomized study of 40 patients showed that you can have much greater improvement in LV ejection fraction. So this study is not published yet, just recently presented at the APHRS in Australia, Sydney. So 200 patient randomized study from China, selecting patients with left bundle branch block and LV dysfunction, and 1-to-1 randomization, 100 patients in each group. The success rate was 98% for left bundle branch pacing and 92% for biventricular pacing. You can see the response rate was similar, but the super response rate was much higher in terms of about 65% at the last follow-up of 3 years compared to 44% with biventricular pacing. And the primary endpoint of death to heart failure hospitalization was significantly reduced with left bundle branch pacing compared to biventricular pacing. As you all know, biventricular pacing is a very effective therapy in this group of patients. You can get even better outcome with conduction system pacing in this population. So the data on right bundle branch block is limited. This is our series of patients that looked at 39 patients. We were successful in 95% of them. You can see the electrical resynchronization. LV ejection fraction was modestly improved in this group of patients. Similar approach with in left bundle branch pacing, we were able to show about 88% success. And we also had similar modest 6 to 8% improvement in ejection fraction with right bundle branch block. There's an ongoing NIH-funded randomized trial in right bundle branch block. Hopefully by early next year, we'll have the results of that. Similar to that, in patients with advanced conduction disease, you can combine heart or lot CRT where you can get better outcomes with LV ejection fraction. There's been a lot of studies, both observational, randomized studies, more than 5,000 patients now studied. So one which had been the limiting factor for acceptance of conduction system pacing because there's almost 10 to 15,000 patients of randomized studies with biventricular pacing. So we're getting there with conduction system pacing, slow but steadily. But in terms of large database, this was a 2-center study showing improved outcomes compared to biventricular pacing in terms of death or heart failure hospitalization. In a multi-center observational study, we were again able to show this was a 4-center study in 371 patients that showed similar improvement in outcome. And this study showed that if you had left bundle branch capture, there was greater benefit in death or heart failure hospitalization. So just left bundle branch area pacing or LV septal pacing alone is not adequate. And this was reproducible in a larger 1,700 patient, 15-center study around the globe. Similar improvement in outcome, both in all comers and in patients with left bundle branch block. So echocardiographic outcomes, greater improvement in QRS duration and LV function, greater improvement in echocardiographic response, and also added benefit of this, not only improve heart failure hospitalization or death, we were able to demonstrate that the incidence of ventricular tachycardia or ventricular fibrillation was significantly reduced with left bundle branch pacing compared to biventricular pacing. So abnormal actuation with biventricular pacing can be a proarrhythmic even in some patients. So you can eliminate that in this group of patients. Furthermore, because of better electrical resynchronization, better echocardiographic response, new onset atrial fibrillation also was reduced in this group of patients. Now, there's been a lot of meta-analysis, again, showing improvement in heart failure hospitalization and even mortality benefit on these large meta-analysis of these patients. So this is another small study, 1,000 patients, looking at patients with mildly reduced LV ejection fraction, 35 to 50%. In the US, it's a class 2A indication for biventricular pacing. Now, conduction system pacing has also been added, but this study provides additional evidence that conduction system pacing can further reduce death of heart failure hospitalization compared to biventricular pacing. Almost all of these observational studies and early randomized studies are showing greater benefit with conduction system pacing compared to biventricular pacing. So what do we do at Geisinger? I don't want to propose that one approach fits for all patients. So in our center, we are primarily geared towards providing a very specific, disease-specific approach. So if we have a patient with narrow QRS, we start with his-bundle pacing, hope to achieve good results by creating the native electrical resynchronization, maintaining the same thing. But we want to get good capture threshold. If you don't get good capture threshold, then we move on to left bundle branch area pacing. In those who have wide QRS, we start with this bundle pacing to understand, is it a correctable disease? If it's completely correctable, then we go on to left bundle branch pacing because it provides us the best pacing capture thresholds. And if you find that the his bundle pacing does not completely correct because patients have mixed conduction disease, then you combine his or left bundle branch pacing with coronary sinus pacing and use that approach. So we tested this in a randomized study, a 100-patient study. So in this approach, I was pleasantly surprised that our success rate for conduction system pacing guided approach was about 98%, while bi-V pacing was 82%. My partners who refused to do conduction system pacing early on, now I can't force them to do bi-V pacing because they are quick to recognize that if you don't get maximal electrical resynchronization with a good approach with bi-V pacing, they don't hesitate to cross over to conduction system pacing approach at this point. So this study did show that overall, the primary endpoint of change in LV ejection fraction was greater with this approach, 12% versus 8% in this group of patients. And so echocardiographic response also was greater. 80% of patients improved ejection fraction by at least 5% compared to 60% with the traditional approach. And so guidelines have changed. Now, Heart Rhythm Society, along with other participating societies, have now come up with new guidelines for patients with bradycardia indications. So if you have, its ejection fraction is greater than 50%, any type of physiologic pacing, his left bundle or bi-V pacing is a class 2B indication if you have a substantial need for ventricular pacing. But if your ejection fraction is reduced, it's a class 2A indication at this point. And similarly, until we have larger randomized trials, conduction system pacing is an early bailout. If you don't achieve good bi-V pacing, then don't accept the move on to conduction system pacing. It's a class 2A indication for almost all of the situations where biventricular pacing is a primary approach. I don't want to belabor these current guidelines, but what it has done is that now the guidelines are higher up at 2A or 2B in most of these patients. But within the next 5 years, we'll have the results of multiple randomized clinical trials, both US, Canadian-based, and European studies that are going to show us what is the next best way to pace. Should we do biventricular pacing or should we do conduction system pacing approach? So I want to leave you with my final thoughts that conduction system pacing is safe, it's feasible in the vast majority of patients, it's elegant in its simplicity, that it's trying to repair the existing conduction problem rather than replacing it with age-old artificial form of pacing, which is often suboptimal. So we want to reinstate physiology in pacing and electrophysiology. Thank you very much.
Thank you for that wonderful talk, taking us through the evolution of this pacing modality. and for leaving enough time for questions. Often we don't have it. And the first question is from Dr. David Byrne.
Thank you for your great talk and all your contributions to the field. A revolution in our field. My question relates to, we're always taught in medical school that so many of these heart blocks were the same in this conduction system. We saw about 5% at this conduction system in the sense of the specific items.
Yeah, that's a great question.
Just because the online people won't know, can you summarize the question?
Yeah, sure. So the question Dr. Burney asked is that historically, we were taught that when we talk about infrahisian block or infranodal block, we thought they were all distal disease. For example, left bundle branch block would mean disease in the distal branches of the left bundle, or right bundle branch block would mean distal right bundle branch block. And similarly, HV block would mean block way down the his bundle system. And when I first started doing his bundle pacing, I was surprised, even very early on with the limited tools, about 76% of those small series of 100 patients when we did originally, we were able to correct with his bundle pacing. Again, that told us that most of the disease was in the his bundle, even though we had clear HV block in most of those patients. When the left bundle branch pacing came along, we were able to confirm that by placing the lead in the left bundle, that you can see the distal conduction system was normal. In those patients whom we found disease in the distal was a small number of patients. Some of them had IVCD-like cures in the setting of complete heart block, or they had myocarditis or cardiomyopathy. Those are the patients that we saw. These are patients who presented with complete heart block or high-grade AV block. But when you extend that to the cardiomyopathy population, that group is slightly different. When you have ischemic heart disease or sarcoidosis or other kinds of disease, then you tend to see more of the diffuse IVCD-like conduction disease. But for the most part, in patients that we see as a bradycardia indication, heart block without heart failure, almost all of them seem to be intrahisian. And that's a huge learning for me, because going back in literature was trying to highlight that the way we thought about intrahisian was if you have narrow QRS and HV block, or you had those split his signals. And that was seen about less than 10% or 5% of the patient, looking back at the literature. That's something we learned by systematically doing his bone pacing in every consecutive patient. And that was surprising for us.
The questions from the room? Dr. Chan wants to speak into the microphone so the online people.
Well, thank you for a very extensive talk on the conduction system pacing. My specific question is, with all your experience, do you have any data on this new mode of pacing on the effect on functional mitral regurgitation?
Yes, sir. So we have a couple of papers out there, both with his bundle pacing and with left bundle branch pacing. And the incidence of functional MR significantly improves following conduction system pacing. And those are especially in cardiac resynchronization therapy patients. And I don't know if it's specific to remodeling that helps improve the function and reduces the functional mitral regurgitation, but it's been a consistent theme that we were able to observe, that functional MR does improve with conduction system pacing. Similar to, we've seen that with biventricular pacing, but much higher percentage than what we saw with traditional biventricular pacing.
Dr. Vijay, in the morning to our fellows, you showed a nice case where there's reverse remodeling in the MR settings. Is that available for you to show us?
So if I can, yeah, that would be
helpful. There's a nice illustration of...
could you help me load that?
Presentation from the memory. because that actually does echo guidance before and after the so I see the
no, it's on the disk here.
Yes, Dr. Goldman has a question. While that's loading away.
Fantastic. Jay, quick question. Are you putting in more DF1 leads now for your ICD CRTs and also when the companies are going less and less, making of the DF1 lead, there's back orders on them, especially when we want to do hot CRT or hot CRT. Find these ones becomes go back to the company and ask them to start making these. What are your thoughts on that? And then there's also this new smaller ICD lead where they're talking about putting it in his location. Work the left on the location. Give us some of your thoughts on that as well.
Sure, I will as soon as. Yeah, so while that's loading, so let me quickly get into here, because that's a nice, as Girish pointed out, the picture is worth.
Also works.
Yeah. So this is a patient with a fairly, 50-year-old with a left bundle branch block and came in with cardiogenic shock. And LV ejection fraction was 10%. You can see the QRS is fairly wide. With his bundle pacing, we were able to partially correct it. So we did a combined left bundle pacing plus LV pacing. You can see the LV activation time. QLV is 210 milliseconds. And final QRS went from 230 to only 170 milliseconds. But you can see the echocardiographic images, because this reason the QRS is fairly wide is the LV mass is big. The LV diameter was about 7.5 centimeters, fairly enlarged. Look at the severity of the functional MR that you were asking. And this is 6 months after. This patient was in cardiogenic shock. Completely normalized LV function. And you can also see the MR is gone. And so that's impressive amount of electrical resynchronization. Even in those patients, you think they're too far gone, both based on the QRS morphology and the LV thinning, this can remodel back. And especially if the primary disease is conduction disease related cardiomyopathy. So that was a big advantage of this particular approach. To answer Medad's questions, so DF1 leads 5 years ago, most of the industry wanted to get rid of it. And thankfully, by pressurizing, pushing, and doing the studies, we were able to stall it. So most of the companies haven't given up on it yet. So they still have DF1 leads. And they still, one of the things was the inventory was hard to maintain. You need a DF1 can with the IS1 LV lead, and then DF4, IS1, all kinds of combination because we're using all different combination. It may merge to become a newer option, as you pointed out. There are ICD leads that have developed which can be used for left bundle branch pacing. So now you don't have to put 4 leads. You can still get away with 3 leads and still have your coronary sinus and a left bundle branch pacing ICD lead. So Medtronic has the first lead that was gone through clinical trials. We have gone through the first phase of it, and we'll be presenting some of the early results on the HRS late breaker this year. But it looks promising. And every company is making those ICD leads, probably DF4 leads, but could be capable of placing it in the left bundle branch location. So we may simplify the process instead of trying to figure out what's the underlying conduction disease. Give them all combination of conduction system plus LV. That's what the industry wants. But that makes it simpler, not have to go through this process of reasoning and figuring out, but still provide the best possible outcome for the patient. Yes, sir.
one group of patients that people have said, including myself, that we can never do left bundle pacing in or hip bundle pacing are the active cardiac sarcoidosis patients, because the concern is the disease is still active and you may lose capture. I just wondered what your approach to them was, and have you seen anybody start to pace them in the septum?
So I don't have a large sarcoid population. I probably have 5 patients that I've done left bundle pacing, some of them with ICD lead too. We published that in a small series using ICD lead, placing them, because the ejection fraction was normal. So insurance wouldn't approve them getting a CRT device. So I had to put a dual chamber ICD in them. So I placed the ICD lead, Dorada lead in them. But we've been able to pace them. We don't know what the long-term outcome is. If there is a CRT indication, then I would definitely do combination. And depends on, we don't know where the disease process is, how far advanced it is. And we do find that when we do left bundle pacing in cardiomyopathy patients, irrespective of whether they have sarcoidosis or ischemic heart disease, there's a lot of patients who have septal scar, and there is significant conduction delay. So when I find those things, I'm always quick to add the coronary sinus lead, or sometimes abandon conduction system pacing and go to biventricular pacing. Our goal is to provide the best possible resynchronization, not just go with just conduction system pacing, not a blind believer in it. Do what may be the best outcome for that particular patient.
Dr. Vijayaraman, thank you so much for a great presentation and all your contributions to the thing. It's really wonderful to see your data. As we all move towards conduction system pacing for the vast majority of patients, as you alluded to, based on the compelling results that we see, of course, we hope we don't have many patients that need to face that. But do you have any data on extraction as we have a larger number of deep septal leads? And what is your experience with that?
Sure. We recently published a series of 340 patients with conduction system pacing. The good news is we have enough data for hip bundle pacing. I have patients with 15, 18-year-old leads come with just manual traction, some of those leads. Almost all of those patients, except for one patient, no patient had any conduction abnormalities with hip bundle pacing lead extraction. One patient developed acute heart block, but that recovered from probably edema during extraction. And 90% of those leads were removed with manual traction. Most of those leads were 3830 leads, which is a Medtronic lead. That's a pretty strong lead for extraction. And as far as left bundle branch pacing is concerned, on the published series, the longest was 3 years. And even those leads came out pretty easily. I now have at least 3 or 4 patients with 6-year-old leads that I've removed. And this is something I do when I pull on the lead, I count the number of cardiac cycles. So far, the 3830 lead comes out with 3 cardiac cycles. Nothing has needed more than 3 cardiac cycle leads, provided there is no additions along with other leads. If it's an isolated lead or 2 leads, it's easy to take it out. We have used extraction tools in some of those leads. The complication related to lead being embedded deep in the septum, we don't have a lot of experience yet. That's something that's worrisome for us, concerning. And some of the stylet-driven leads are not as strong. Even with the 3830 lead, there's occasional cases of fracture and leaving behind the distal components in the septum. So that is an area of concern. We need to design leads that could be easily removed from this region. We don't know. So that's something we're continuing to accumulate data.
Any other questions? So, Dr. Cole. One, is is there any patient that you would not try left bundle pacing on? How hard do you try before you say, okay, I've poked enough at the septum before you give up, just practically speaking?
Yeah, it's a great question. So it's almost always the patient in front of you. Is that right? So if you have a patient with bradycardia indication, sinus node dysfunction, and I think in North America we always use a dual chamber pacemaker even if you have sinus node dysfunction. So I would attempt 2 times, and if I get left septal pacing, probably acceptable. But if you have high need for ventricular pacing, I'll do my best effort. And rule of 5 attempts, I would do, or 20 minutes of fluoro time, whichever comes early. I would say that early on, as your experience goes, you understand where, why, and where you were not able to achieve the success that you want to achieve. So you need to move on. In the beginning, depending on your lab needs or how many more patients you need to take care of that day, then you can set a certain time limit. I'm going to spend an extra 10 minutes for this patient. Before you know, once you do 10, 15 cases, your experience has gone up and you figure out and you get good at it like anything else. But it's worth spending those effort because it's going to reap huge dividends in the long run for this patient. For cardiac resynchronization therapy, I may try harder, especially if I think it's a pure left bundle branch block. And if I can correct with this bundle pacing, I would do my best to do left bundle pacing. But again, there's a limit. And if you do 5 deep septal attempts and I'm not getting the results I want to get, I will move on to coronary sinus pacing at that point.
We have a question online, Dr. Vijayaraman. So it's from Kevin Day. So he asks, in heart failure patients requiring defibrillation, CRTD, have any concerns been encountered in the interaction between RV apical defibrillation and the RV LVDA?
Yeah, it's a great question. We learned the hard way. So when we there's been some concern about lead fractures we talked about briefly. 3830 lead is a very sturdy lead. There's been more reports of lead fracture with the styler-driven leads. So we had the first lead fracture of the 3830 lead. It was because the left bundle branch pacing lead was placed too close to the ICD coil. So the back end of the ring electrode and the ICD coil were close contact and they interacted. So our approach is to, just like the old days when we did ICD leads or added an ICD lead, you don't want the interaction between these 2 leads. And so I would make my best effort. Now, I don't place the defibrillator lead in the outflow tract location because that's when you often have interaction. So place the lead in the apex and then you do the left bundle branch pacing lead. You have enough room to avoid lead-to-lead interaction. That's something we need to avoid because there's potential. And we did some bench studies on that too. Lead-to-lead interaction can go both ways. Your left bundle lead can be damaged as well as the ICD lead can have erosion and fail too. So we need to be careful avoiding that interaction.
Yeah, and the rest is a question.
Thanks for the presentation. It was really amazing and really exciting field. This is more a technical question. What's your first option in terms of sheets, and what do you do in those cases that the ventricles too dilate or anatomically is challenging and you need to change the sheet? What's the first options? What's the second one?
Yeah, so my experience, because I've been using the 3830 lead and the Medtronic sheets for the longest time, for almost 20 years, I'm very comfortable with it. I can make it work for most scenarios. If I can get it with the C315 sheet, then I move to the deflectable sheet. And sometimes I go back and forth. And sometimes I combine, jerry-rig some sheets, use a CS sheet with a C315 in combination for better reach or support. The good news is there are more sheets on the way. You know that all of the styler-driven leads have much more sturdier sheet that can help. Boston Scientific is coming out. I think you don't have it yet. They've come up with the next set of generation of sheets that are much better than the SSPC sheets. They're also called SSPC, but different letters, Y and Z or something like that. That seems to work well. Medtronic is going to have a longer sheet. One of the limitations is that sheets are not longer. They're coming out with longer sheets, hopefully sometime this year. And there's going to be improvement in leads. I think Biotronic is, if we are in the trial phase for their fixed screw lead, and Medtronic may come out with another longer screw lead for conduction system pacing. And as far as I know, Abbott and more than Abbott, Boston Scientific also working on a dedicated conduction system pacing lead. So far, we've been using leads that are traditional leads, and we are using it for conduction system pacing. Now we are beginning to see leads designed for conduction system pacing. And there may be a late breaker presentation on conceptual leadless conduction system pacing from Abbott. I think you heard about the reports, acute studies, and they're presenting some of their experiences on HRS this year. So more to come on that.
Well, if there are no other questions, then I request Mr. Marr to present Dr. Vijayaraman with a thank you plaque.